And we're live. Welcome back, everybody, to our latest episode. And Happy New Year, by the way, to each and every one of you especially. So, we made it through 2023, and what better way to start the new year but with an emergency? Critical, fatal, bloody, gory accidents. And we know they all happen, especially after midnight. So I hope you've been able to stomach our presentation this evening because some of the content may be disturbing. Those of you who've been tuning in and growing up watching those TV shows, ER and Grey's Anatomy and Code Black, you know what I'm talking about. So you can expect a lot of some gory, exciting stuff to happen in the ED. And this is one medical specialty that covers a lot of traumatic injuries and deals with every organ system. So ED and ER coders will see evaluations, minor and major surgeries, and maybe some strange cases like elephant attacks, helicopter collisions, massive mayhem. And that's what you can possibly look forward to. But on the other end, sometimes there's drab days where you have just cough, nausea, dizziness. It's all a whole spectrum of coding in one place. So tonight we have two panelists. We have Kelly Hepner, who will be discussing her daily routine as a coder for eCatalyst Health. Kelly is a CCS, COC, CDEO, and a CRC. She codes for ED and ancillary facility coding at eCatalyst Health Solutions. And we have Lakeisha Paris, who is a coder at UC San Diego Health and is one of the top SMEs in ER coding for the AAPC. And she's going to be talking about advancement, skill requirements, and how to improve yourself as a coder in the ED specialty. So let's get started. I'm going to start with Lakeisha. So what does ED coding entail? What are some of the common things you see in ED? And I know we talk about elephant accidents and helicopter collisions and just mayhem. Do you see that, and what can we expect in this job?
Oftentimes in the ED, it can include anything from primary care services to trauma services. Patients may come in with a respiratory failure, cardiac arrest, which may lead to CPR being performed, intubations. I mean, it's a plethora of, I mean, of course, you're going to the emergency department for maybe the common cold, or patient might fall off a bike. Simple things like that. But it can get, I mean, with CHF, congestive heart failure, patients that have chronic conditions like diabetic patients, sometimes they may have elevated blood sugars. So that's treated in the ED also. And some physicians, some of the ED physicians, they do have subspecialties. I've worked for an ED physician group that some of them were trained in critical care medicine as well as pediatric emergency medicine. But for the most part, when a patient presents to the ED, sometimes they'll have to consult with other specialists, such as if a pregnant patient may come in and they may have complications, so they may consult with OB or ortho. They may have to consult with an orthopedic. It just depends on what the patient presents to the ED with.
And how about you, Kelly? Anything you want to add to that? Things you see typically in your daily routine as an ED coder?
Yeah, so I have never worked for like a trauma level 1 facility. I usually it's like 4 or 5, so I don't see those crazy cases. But I have seen, a lot of fractures, a lot of viral illnesses. Right now, it's all COVID, flu, and RSV that I see a lot of, and I code a lot of. Yeah, but definitely fractures, car accidents, stuff like that.
So what are some of the ER coding complexities? So, some things that you don't normally see in like the office setting or, the inpatient setting. What are some things that kind of throw you through a loop? Things that you would have to like really pay attention to in the notes.
Sometimes the percent, depending on like Kelly was saying about the trauma centers, if it's a level 1, 2, or 3, because the complexity of the cases vary. And a lot of times, most of the time with level 1 trauma centers, that's where you're going to see the most complex cases because it's a lot more trauma. So you're coding a lot of, again, the intubations and all the cardiac failures and central line placements. You're going to get into coding more procedures. So, and you may come across even some procedures that you've never coded before when you have to reach out to your team. So it's a lot of learning. Definitely a lot of learning.
So when you talk about those class 1, I'm sorry, was it class 1, class 2, and class
level 1 trauma center?
Yeah, level 1. What are those levels mean? What does that indicate to that ED?
The level 1 trauma centers can usually handle the care from the beginning to the end. Level 2s, they can handle like some of the definitive care, but the level 1s are the ones that can handle everything from the beginning to rehab. And you can learn about those from the American Trauma Society. Usually you can just kind of Google the trauma levels and you can learn more about each level of trauma centers.
And those are the things we've seen growing up on TV, like, just the really bad stuff, the train wrecks in the subway that hit a school bus. Like those are the class, or the level 1 traumas. Have any of you ever seen anything really, really bizarre in your time as an ED coder?
Well, I had one where it wasn't trauma.
HIPAA compliant, of course. Try to be.
I'm trying to keep this PG-13. There was one case, it wasn't trauma, but it was a crazy one and it was a teenager, and he came in and he had glued all of these different fruits all over his thigh. And it was like, I don't know, he said he used different, it was like crazy glue, and he sprayed Flex Seal and other, it was just all over his thigh. It was one of those parts where you could see the pictures. So it was just all over. I don't know what possessed him to do that. But he actually had to end up being transferred to a pediatric hospital for that, because if they tried to remove it, it was like it was kind of pulling up the skin. So, and you could see all of that.
Oh my gosh. Yeah, mine would probably just be like people sticking things where they shouldn't, and the weird things that they use.
Yeah, that too.
Yeah.
Somehow I knew that was going to come up in a conversation today, and I will save the audience the chance to ask it, because we're going to talk about it right now.
Yeah,
so,
okay.
Odd things in odd places. You need to clarify that for us.
I've definitely seen some very graphic when it comes to STDs. That looked very, well, in their private areas. That was,
Yeah.
Yeah.
So for the audience out there, if you can't stomach this, maybe ED coding isn't for you.
But if you like being entertained, then it might be for you.
It's never a dull moment in ED
coding. It keeps it interesting.
So let's put a disclaimer on that. This is not the place to go to tell stories to your family.
Yeah.
Again, you have to be HIPAA compliant. We go in as professionals. Yes, there'll be some interesting things you will see, and you get to see some of the really bizarre cases, and you keep them to yourself. You be professional, but if you're not of this person that can handle that, maybe something else, not a level 1 trauma center is probably the place you don't want to be. Level 3 could be. I do some ED coding, and right now, this time of year, it's all flus, runny noses, and coughs. 90% of the cases. So again, a lot of them are going to be routine, and of course, some routine is good. Occasionally, you need that one case just makes your day. But this again, a wide range of topics. We've seen a lot of things with the gluing of the skin, dermatological. We've heard and talk about foreign body removals from, when I say foreign,
Yeah.
It's definitely important.
but like, what are some other things that you might do in the ED? Like, what are some kind of other services that ED providers would do that you might not see in an office? Something that, if you're kind of preparing for this, what are some things you should kind of read up on?
Infusion coding.
Yeah, I was just gonna say that.
Yeah,
Yeah.
definitely, because the ED entails the pro fee and professional side. So on the facility side, you're going to do infusion coding. So you definitely want to have it read up on your infusion coding if you want to get into the ED facility side. And in some cases, you're going to do both, which is what they refer to as single path coding now. And which is what I've been doing for like the past 4 years, doing both simultaneously, the pro fee and the facility side. And the facility side includes determining those E&M levels it's determined by the resources utilized by the facility, whereas the pro fee side is what the physician actually does, the medical decision making.
So it's like labor versus supply, like
Yeah,
actual.
pretty much.
Okay, that's a good explanation. How about you, Kelly?
Yeah, just to add to the injection and infusion coding, definitely like knowing those by heart. They can be complex, just knowing like the time, whether it was an infusion, an IV push, or it was given subcutaneously. And then, you can have hydration running at the same time. So you just really got to know and look at the documentation, especially now with like for my facility, it pulls those in from the documentation, and sometimes they're wrong. Like maybe they put an order in for the patient to have an injection, and then the patient refused it, but it's still in there. So definitely looking at documentation for those.
Yeah, I agree.
Yeah.
Now, do they typically have their own independent op report, or do they merge like these procedures like into their plan of care where you would hunt for them?
Usually the procedure is within the documentation, or sometimes there'll be a separate note. And sometimes you'll get documentation where they'll say they actually performed the procedure, but the documentation is not there. At which time you have to initiate a physician query, because it's like, okay, per the documentation, this was done, but there's no procedure note.
So you mentioned earlier about, some of the ED providers are trained for critical trauma care. What are some other kind of ED, like, I want to say, ED specialties? Like in the ED, do they have ED doctors that are, like I said, just pediatrics, or there's ones that are only ED trauma? Do you see a lot of different classifications?
Most of the time, they're just consulting with other providers in particular specialties, depending on what the patient presents to the ED with. I don't really usually see a lot where they're specialized. They're mostly just consulting with other providers.
Yeah.
All right. So that 21-year-old athlete that was doing whatever kind of a track and field that takes that a javelin to the chest, comes in, and there's all craziness. We need paging Dr. Mercy, and they have to consult for a nephrology, ortho, cardiac, because this one guy took a javelin through the heart, through the lungs, to the liver, to the pancreas, and somehow his foot. So how do those kind of cases happen? Like when they do a consult, is there one guy leading the show, or is there some kind of transfer down the line?
Usually, well, especially in teaching facilities, because most of the facilities I work for have been teaching facilities, the resident usually will come down to the ED at the patient's bedside, and then of course they'll have that attending that signs off on it for that particular specialty. And whatever they recommend is what the ED provider usually follows that recommendation, which also is a part of the determining the EM levels as well, just based on those discussions. So they're not usually transferred. They usually come to the patient's bedside.
Okay. What are some instances where there will be some kind of patient transfer, like for an admission, or if they're not able to handle this patient, like what happens then? Like how does that affect your job as a coder when they only half treat or they don't treat to the the at the end outcome? They just
Now, if they recommend admission or transfer, it's usually either they're going to recommend admission or they're going to transfer that patient to another facility that can handle it.
Now, I've also seen a lot of ED patients where the patient's there for 4 hours. So coding on time, I know is not a thing, but how do they kind of count for that 4-hour period?
Those extended, so what they call extended stay EDs, the
Yeah.
documentation definitely has to be there. And oftentimes they'll have separate coders handling those cases. So one coder is not responsible. It's like once they're admitted, it's like one coder. Some coders will handle the ED admits. And then the other coders are only going to handle up to the point before that patient was transferred to ED or still in the ED, those extended stays. Every facility handles those differently though.
Yeah.
So like what happens if the patient comes in and they see a Dr. Hopper, and then an hour passes and it's the end of rounds for Dr. Hopper and then comes Dr. Cooper. So they have two doctors seeing one patient because of just a long ER period. How do they coordinate that? What is the coding provision when you have two doctors on the same day? Because that would be something I would think would happen.
Sometimes that does happen, and that's again, those are cases that may be passed on to someone else that handles those type of cases. And because usually the one who's going to get the credit is the one that performed the most work. So even if two doctors are seeing that patient, it's still going to be credited to the one that does the most.
All right. So patient comes in and he has difficulty breathing, and they say, well, we need to get him up for radiology CT.
Mm-hmm.
And during that CT, patient A leaves. He's like, I'm gonna, it's time for me to go home. My round's over. I've been here for the 18 hours. I'm giving your care to, Dr. B. And Dr. B, he looks at the X-ray, looks at the radiology,
Mm-hmm.
and the imaging reports, and then he makes his recommendation. So, do you typically have any kind of rule on how that's coded? Is it A versus B?
Well, then you're going to code where the final diagnosis is going to be coded based on what that discharging provider, the last provider that saw the patient, those are going to be your final codes.
Anything, Kelly, you want to add to that, or anything like you've seen with multiple providers in the ED, like of that same specialty?
Yeah, so from just the facility side, I would just be looking at both of those ED notes and pulling diagnosis from both of those. I don't really do the E&M level coding at my facility because they have it set up where the system does that. I'm checking those, but I mostly just do the facility side, so
Okay.
I'm not super familiar with how the physicians would work in their billing.
So I know for inpatient and observation, you code for like an 8-hour period. How do you code for like an ED visit for the facility? You code for like if you're there for an hour, 2 hours, 3 hours worth of bedtime or nursing care. How does that work?
Now for observations, I haven't done observations in a while. It's probably been several years since I've done observation, but they usually have a set of observation coders that does observation. So
Yeah.
they split those services out.
Yeah, I know. Like when you actually code for observation, like they bill for every 8 hours. But if there's anything like that in ED, where like there is some like kind of like there's one facility code for like ED time. Like he was here for say an hour, 2 hours, 3 hours. Like what is the unit breakdown for like when you're coding for an ED facility for like the ED services?
As it relates to observation.
No, just for ED.
Or just if the patient's there, like from what, say they came in late at night and then they were there until the next day. Or they were there for a really long time.
But it's just coded like a straight ED.
Yeah.
Okay.
Yeah, that's just coded as a straight ED.
Okay.
Yeah, the infusion, if they had, infusion, that might get a little tricky just with the different days. But yeah, I think the E&M level would be pretty straightforward.
Mm-hmm.
Okay. All right. So let's talk about what your day is like. What is your set routine? You go to your desk, you sit down, you turn your computer on. What do you typically do from point A to point B? When you clock in to your home, like what is your normal routine on a normal, uncrazy ER day?
Well, for me, I get for first I check my emails. That's number one.
Yeah.
Then I get everything pulled up. Epic, which is the EMR that's utilized, or if some people use Cerner, I pull that up, and then everything, all the policies and procedures the facility has created, everything that I know that I'm going to need to review as I work each chart. I work all of my oldest because you have your different work queues set up. You have your old charts, you have your cases that maybe have been missing documentation. The physician may have responded to those queries. So you're going to work those work queues first. Then you're going to start coding your uncoded ED charts. That's what I do.
How about you, Kelly?
Yeah, mine's pretty similar. I actually work part-time. I'm not full-time, so I don't have a regular 8-hour day, but I work part-time and pretty much the same thing. Check email, Teams, log into everything, and then check the older charts that we were waiting on documentation for, and then I just start coding whichever day I need to start with.
All right. So let's think back to when you first began ED coding. What are some of the things you had to learn in order to kind of get a grip on what you were doing? Like what are some things you need to know kind of going in before you start any ED coding? I mean like any kind of clinical or any kind of procedure stuff. What are some things that any coder that wants to learn ED should know or start to learn now so they're ready if they do want to apply for a job?
Make sure that you know your anatomy and even pharmacology, because in ED coding, you're going to be picking up long-term meds. So you need to be familiar with those medications for like those chronic conditions, medical terminology, your ICD-10 guidelines, and brushing up on your EM leveling. Because for the ED, of course, the guidelines changed this year. Well, last year, January of last year. So you definitely want to read up on that. And you can do that by American College of Emergency Physicians. It's a great resource. I don't think it should be the only resource, and it's not to diminish ACEP, but I think a lot of facilities weigh heavily on their guidance. But I think when it comes to the complexity of the problem addressed, it can get tricky. And because even last year I worked for multiple facilities where applying the 2023 guidelines, but no facility was synonymous in their interpretation of the guidelines. So it's like you had to put on more than one hat because not every facility does it the same. So you want to make sure that you're understanding how the facility are applying those guidelines.
How about you, Kelly? Anything you want to add to this?
Yeah, definitely guidelines, especially for like the common comorbidities, diabetes, hypertension, see those a lot. I'm trying to think what else. Yeah, I wrote down some things and I can't find them, and I can't think off the top of my head what else I was going to add to that. But yeah, for sure, guidelines.
When I think of ED, I think of accidents, messy accidents. So can we talk about external cause codes real quick and other traumatic injuries, and kind of give a walkthrough about some of the kind of complexities of coding those kind of diagnoses?
Like the car accidents and the place of occurrence.
Yeah, the place of occurrence code. Patient comes in. All right, so let's have a scenario. Patient gets hit by a moving vehicle. We have a left leg fracture of the of the distal femur. Breaks the skin, and turns out that they were hit by a car while in their living room. So just make this weird. They're in the living room watching TV. Car comes in. They're in the recliner. The car stops just short of the inside of the recliner and breaks their leg. So Jaws of Life called in. Fire department tears a hole in the wall, take the whole recliner out. The car is still fused to the chair, to the leg, and they wheel him out in glorious fashion like you would see on TV. So we have this traumatic fracture happen in the living room, and he was hit by a vehicle. How would one code that specific situation? Like, I know there's a different combination of codes you would have to do. I'm not asking for the actual true answer, but I know there's a certain order you have to follow with that.
You're gonna code that fracture. Yeah. You're gonna code how it happened, where it happened. Sometimes that may, and even the activity. What were they doing at the time? And sometimes that may include more than just, maybe more than one external cause code, because you're painting a picture. Okay. So it can be more than one.
Yeah. So what we're saying is there would be some kind of injury code first. So first diagnosis code on the claim form should be
the fracture.
The fracture. Item number 2 would be the
how it happened.
So
it would be
by car.
Yeah.
And then item number 3 could be
the place of occurrence.
Place of occurrence. Living room. So tells a story. You say you submit the claim to the insurance company. Hopefully it's they actually got the actual motor vehicle insurance from the driver. Because God forbid you try to submit that to Medicare. Problems. But you're in your living room, coding the place of accidents as the last code. What happens if the guy has, he gets hit by a car in his chair, and the whole terror of it just sends him into cardiac arrest? What would you do with that? And so he's brought in, leg fracture. They have to put the paddles to him. Is that something you would code in addition to the fracture, or is that something that you would possibly think, well, it's a sign and symptom of fracture?
You're absolutely going to pick that up, especially if they're addressing it. Definitely. Yeah. Anything that they address, you're definitely going to pick that up. Because sometimes even it doesn't, the diagnosis doesn't necessarily have to be the final diagnosis, because sometimes they'll have all of these ancillary studies that they've performed. In the final diagnosis, there's no diagnosis to cover why they performed an answer. Because if a patient comes in with chest pain and you're doing a knee X-ray, okay, and there's nothing in the final diagnosis that's saying why did you perform this knee X-ray, well, you need to look over that documentation to make sure you're matching linking that diagnosis to that ancillary study.
And it could be hidden in the HPI, the physical exam, where the patient complained that their knee hurt.
Exactly.
Yeah.
What if it's a really bad case where they were doing jumping jacks and they fell really hard on their knee, and the knee just made its way into the thoracic cavity, and now they have to X-ray the knee, which coincidentally is also in his chest? Could that be a situation where you can get paid for knee pain? At the same time as a chest X-ray?
Well, if there's something like Kelly stated, if there's something in that exam or something in that documentation that touches on something happening with that knee, then yes.
Yeah, I imagine it'd probably have to be fractured at that point.
Yeah.
The ED could be interesting coding. I've been doing ED coding for the past 2 weeks because we have had a higher volume this time of year, and some of the things that you see, again, I've seen a lot of the kids come in with running noses, but a lot of interesting cases, and you really have to pay attention.
Mm-hmm.
What are some things? What are some kind of notes and some kind of different kinds of documentation that you typically have to read in order to get your end code? Like, do you have to hunt around, or are there certain things typically you look at, in addition to like the ED visit, like the ED note by the doctor?
Now, sometimes, like for those chronic conditions, like for instance, well, just say the patient presents to the ED and they have hypertension, and you look at the history, that patient may also have heart failure. So you definitely you're not going to just pick up hypertension in that case. You're going to pick up hypertensive heart failure because you've reviewed the history and you've seen that documentation.
How about you, Kelly? Are there any other things that you typically in your daily routine, like just to be 100% accurate with your coding? Are there other kinds of notes that you look at, like different types of documents that make coding easier?
So, the guidelines are that you should really only be pulling diagnosis from the physician's documentation, obviously, but sometimes, for my facility, if the patient has obesity in their history or the physician says they have obesity, we can pull that BMI from nursing notes. Maybe where they triage the patient and they took their vitals, their weight and everything, we can pull it from there. I think that's pretty much it. It's mainly the ER note that we're reading.
Okay. So you can pull information from other notes that's codable, even though it's not in the end assessment. Like, what are some other sources you can take from an extra code? Like you said, you can code to BMI. Are there any other kind of neural factors or any other any other Z codes that you can code from the history without them being confirmed? That provider hasn't confirmed them, but somebody else has, like the ambulance driver or the nurse. Like, what are some other services that impact your code selection?
Now, sometimes now just for the facility side only, you can pick up additional codes from the consult notes, but not for the prophy component. And the nursing notes, like Kelly said, the nursing notes can be helpful in confirming what was actually done, because oftentimes in the ED note, they'll state, oh, we applied a splint, when it actually wasn't done. Because once you read those nursing notes, you'll see that it wasn't actually done.
Yeah, or it's helpful for, like your example, if they do a splint, but the physician doesn't say what type of splint, we can look in the nursing notes for that too.
Yeah.
Okay. Yeah. All right, so let's see what else we got here. So what are some of the obstacles that slow down your coding? Like, what are some things that you really have to watch out for, because they can really hinder your productivity? And what are some things you do to kind of correct that? You talk about queries, but what are some other things that could really slow down the process?
Incomplete documentation.
Yeah, that was mine too.
That's the top. Is incomplete documentation.
Yeah. Or a recent example that I've had is, RSVs going around and the physicians are just putting that the patient has RSV. And according to the guidelines, you can't code just the RSV because you need a primary diagnosis for that. So such as pneumonia. So RSV is the underlying cause of the pneumonia, but you can't just put RSV. Mm-hmm. So if the physician is just putting that, we're having to, query them.
Okay. So what is the hardest part of your job? I know it can be interesting times and fun, but like, what are some things that you really, when you know they're going to happen, you just like cringe? You're like, is that really the case I'm going to go home thinking about? What are the hardest things you like? What are some of the hardest parts of your job?
Let's see, the hardest part. I can't really say there's a hardest part. As it relates to cases. I mean, other than maybe some technical issues.
Yeah.
But as far as cases, I just pretty much take on everything. I mean, I like a challenge, so I just pretty much take on everything. And if I have to reach out to maybe the auditors for assistance, then that's what I do, or even my teammates.
Yeah, an example here, because I'm in Arizona, when I was coding for an Arizona hospital, the state requires the place of occurrence for all the ER accounts. And so something that was frustrating working for that or doing that, we were always having to find the place of occurrence for an injury. And then we'd have to send them back to, the ED department if they were missing. So that was kind of frustrating, but that varies by state. So like I code for a facility now in South Carolina and they don't have a requirement.
Okay, so not a lot of difficulties. Basically, it's very kind of cut and dry when you're coding. There's really not a lot besides insufficient documentation that really slow you down. So let's talk expectations about productivity. Now, I know every place is different, but what is the normal range for what you do, say, per an hour or per day? Like, what are some things that your output is, and what's reasonable for any kind of new coder or any expert coder, in your opinion?
Well, in my opinion, if you're doing both simultaneously, I don't think it should be any more than maybe 3 to 4 an hour, especially when you're picking up, you're having to look at everything in its entirety, making sure you're not missing services or supplies that some facilities require you to pick up. But if you're doing just pro fee only or maybe just facility only, I would say maybe 7 to 8 an hour, possibly. And that all depends on the type of cases that you're seeing. Now, if you're at a trauma center and you're getting a lot of trauma, I mean, you can be in one case as long as 30 minutes. So that can vary from facility to facility.
Yeah, for sure. Like mine is 12 an hour, but I'm coding flu and COVID most of the day, so I can do way more than that usually.
Okay. So let's see. Let's skip this question. So once you have a coder that learns the foundation and knows the ins and outs of the daily routine, what's the next step for that coder? Like, what is if you're an ED coder and they want to become a higher level ED coder, what are some of the things then they need to do to kind of develop themselves as an ED coder?
Well, usually the progression level is like 1, 2, 3, and 4. And in some cases, even at a level 1, depending on what facility you're at, you're going to be cross-trained on everything, like maybe same-day surgeries, observation, maybe even some other outpatient services or inpatient services. So, and just with ED alone, I mean, you can even, there's a lot of YouTube videos where you can learn about emergency department coding with EM leveling. You can learn about the different EMR systems, because sometimes even with working at the same facility, even though there's multiple facilities within that health system, they may use, one facility may use Epic, another may use Cerner. So make sure you get exposed to those EMR systems, and there are resources on finding those, like on YouTube. Again, I've even the coders that I mentor, I say, go, if you've never been exposed to any EMR systems, make sure you get familiar with those. There's Epic, there's a video on Epic as well as Cerner that kind of shows you how it works. And even with the encoders like 3M, Optum CAC, your computer assisted coding systems, just kind of see how those work if you don't have experience with those. And definitely your infusions too. You want to learn about your controlled substances, because sometimes that plays a part in your E&M levels. So.
How about you, Kelly? What are some of the things that you would recommend if a coder wants to advance in ED coding? They find they like it and they like the excitement of ED coding, not just COVID and not just flu and nausea and vomiting, but they want to get better at it. What are some of the things they can do to advance and possibly become a better ED coder? Or if they want to aim for that to be their career for the next 30, 40, or 50 years.
Yeah, I think, seeking out those jobs where they are higher trauma levels would for sure help. I think a good progression, if you wanted to, move on from ERs, would be like observation coding, which is kind of some of what I've done, surgeries, because you kind of get a little taste for fractures and stuff in the ER. Yeah, can't think of anything else.
Now, when you say taste for fractures, do you see a fair amount, or is that just something you see occasionally? Because I would think that would happen at least every 2.5 minutes.
Yeah.
And then bring them in one after another.
Yeah, I think it definitely depends on where the facility is too. I think the one that I code for is more rural. And I don't see a whole lot of fractures, but when I used to code for where I live, I definitely saw a lot more fractures, and it's, more of a city. So I don't know if that has any correlation. Maybe people are out doing more things. I don't know.
Yeah. Where I was from, where I live, I used to work for this area by the ocean in South Jersey, and we saw a lot of alcohol-related boating injuries. That was a big thing. Boating injuries, people that should not have been manning that mini wheel or the jet ski. That was more common than fractures, but I guess it's all per area. Your region, I'm sure you have a higher incidence of, certain injuries. Like if you were in, say, somewhere like Alaska, frostbite or moose attacks, just pulling it out of a hat. Florida, sunburn.
Yeah, I've actually coded a lot of people hitting deers. And I'm in Tucson, Arizona. We don't have snow, so I think there's a lot more animals, back east or whatever. So.
Okay. But you do see a lot of unique things.
Yeah.
So,
and even with your critical care, you want to make sure you know those critical care guidelines too, because that's a whole set of different guidelines. That's a requirement that has to be met for that. You have some positions, they'll do critical care for everything. I remember when I first started coding, there was this one physician where, I don't know if he just liked writing critical care time, but a child could come in, fall off a bike, scratch, send him home, and he'll go critical care 45 minutes. Seriously?
Well, you also have to watch too. I've seen a lot of physicians where they'll just they'll copy and paste the what is it called, for their note. They'll just copy it, and it will be like they didn't actually write critical care. It's from a previous note. Mm-hmm. So yeah, you have to watch out for that too.
Yeah.
So what are the requirements for critical care? Because now you open this can of worms. What are the requirements for? And I think there's three of them, three major ones for Medicare for critical care.
Yeah, and first of all, it has to be a minimum of 30 minutes, and they have to at least document the assessments if there are any frequent assessments done. Not just say critical care 45 minutes and then you didn't do anything. No interventions. No nothing. It's because I know for some facilities, it's like they'll just accept that they put critical care 45 minutes and they haven't met the requirement. There's no frequency as did the patient, if you provided meds for this patient, how did they improve after? Or nothing else is you've got to document all of that in order for to meet that criteria.
Yeah. I think the major requirement for critical care is the patient's critical. Like you said, falling off the bike.
Yeah.
Not immediately life-threatening. There has to be an imminent or high risk of impending life-threatening risk of the patient's life. Mm-hmm. Also, any treatment you provide to offset that high impending risk of loss of permanent function or life is one of the other ones. So the actual main complaint is a critical one. your care is of high complexity and is used to offset that critical state, and you spend a large portion of time doing that service.
Mm-hmm.
Like I said, more than 30 minutes. I think it ranges to like, I think it's what, 30 minutes to 72 minutes for one unit,
Mm-hmm.
and then everything after that like a half hour
Yeah.
Per unit. But yeah, the major thing is they have to be critical.
Yeah. Is it impacting an organ? I mean,
Yeah. And then what procedures did they do? Because some are included in the critical care and some aren't.
Right.
So
Yeah, that's the hard one. You got to read your guidelines and know what's included, because there's a lot of odd things that are included and some aren't.
yeah.
Like for example, I would always assume that CPR included. If you're
Yeah.
doing CPR on a patient, that's probably like one of the things that's like first thing you do. The person comes in blue. But I think CPR is actually payable outside of the critical care services as its own code. Things like ambulatory EKGs and pulse oximetry and intubation, I think are included in critical care, but not everything.
Right.
Like I think you really have to know, and I think that's something like you'd want to have tattooed on your inner arm, just to make sure that when you're working, you can just pull your arm up and be like, "Hey."
And that differs for the facility and the pro fee, whereas the facility can actually code those procedures, but on the pro fee side, they can't.
So critical care, how often do you see true cases of critical care? I mean, I'm thinking the ER would be something you would see daily, but how often is it truly supported?
I think it definitely.
Yeah, it depends. It just depends on the facility, actually.
Yeah,
it really does.
I saw quite a few more at the last facility I worked at, but not recently at the one I'm currently at. So
same here.
Yeah.
All right, so tools. Let's talk about tools you use in your daily routine. We talked about encoders and the EMR system, but are there other things beside the normal CPT book and ICD-10 book that an ED coder should kind of become well versed in order to be successful?
Now, again, a few of the facilities that I work for, they rely heavily on the American College of Emergency Physicians for their EM leveling. So I would say be familiar with that. And again, I think it's a great resource, but I don't think it should be the only, because there are some variances when it comes to this, particularly with the complexity of the problem and the systemic symptoms. In my opinion, again, I feel like some of those conditions that are listed there, I don't feel like it should be automatically moderate, because the EM level is based on what was actually done. So you don't know that until you look at the documentation in its entirety. So for that reason, I don't think it should just be automatically moderate for particular conditions. That's just my opinion, because I feel like it leads to a lot of upcoding.
Okay. How about you, Kelly?
Yeah, I'd say definitely the coder's desk reference for CPT codes. I look at that like every time I code a procedure. And that just kind of gives you what the procedure is in layman's terms. So it's super helpful. And then the coding clinics, for sure, stay up to date on those.
Okay. Do you see a lot of cases that require those coding clinics, like a lot of, diagnosis related things that are kind of gray area? Do you see a lot of what are some of the things that you would refer to the coding clinic for?
Things that I have in the past are like COPD, especially that in the ER, because we see that quite a bit. I'm trying to think what else. Can't think of anything else right now.
Okay.
Something I definitely reference.
Yeah, for those who are unaware, coding clinics are kind of like add-ons to your ICD-10 or CPT, where they give further rationale and explanation of why we code hypertension with heart failure, or like what the rationale is with coding coding pneumonia with bronchitis. What are the just odd abnormalities that you'd have to look up. So there's a lot of and I think they come out every quarter. They're updated quarterly, but it's like odd cases where there are coders that say, how do I code this? Because this this come up, and there's kind of conflicting information. So the AMA goes in and they do their AMA thing, and they say, well, using our kind of theory behind coding process, we believe you should code it this way, and they'll reference whatever guidelines. So that's a good source when,
just to keep up to date on, make sure you're looking to see what's been updated.
Yeah.
And CPT assistant helps with procedures too.
Yeah. One thing to know about that is Medicare. Now, you might not see Medicare online in ED, but you might. Medicare doesn't always recognize CPT assistant. They recognize a lot of things in CPT, but they made a categorical statement in their NCCI manual, Chapter 1, that CPT assistant is more of a guide, but it's not like a rule that we follow. Sometimes they disagree with those, so they don't use that. But some payers do like it. Some payers like, yeah, use CPT assist. Your Blue Crosses, your motor vehicle might actually refer to that because it's easier for them to cling to that guidance. But just be aware of how you use it. So we're about 10 minutes from the hour. So let's talk about one last question with the ED certification. Now, I know this is something that you have, Lakeisha. So the ED certification, have you felt that it's helpful having that certification? Do you think that's something that a lot of places look for? Or is that something that you have just to kind of highlight your expertise?
Now, I've done a lot of contract work, and a lot of those facilities have required it. It was a preference to have the CEDC certification. But for me, at the time that I obtained it, it's because I had been doing ED coding for a while, and that was my specialty. So I decided to pursue a certification in it. And at the same time, I learned a lot, even from that study guide, because at that time I purchased the practice exams from AAPC, and it was helpful. And I felt like it helped me grow as well, not just for working for particular facilities. And it showed my expertise in that area. So
how about you, Kelly? Do you have any plans to take any kind of certifications based on your experience in ED? Like, do you want to explore other areas?
I mean, I've been coding EDs for 10 years now, so I probably should get the CEDC. I think that's next on my list. I just got the CDEO last year, and then the year before was the CRC.
Yeah.
So yeah, I kind of, I've always loved the ERs. I've done ancillaries and some observations. I love to get more into maybe the observations at some point, but I also love doing the edits, which was something else I was going to mention. If you go into ED coding, definitely watching your edits is something to look out for, the NCCI and LCD edits. So
yeah.
Now, do you, from your experience in ED, is any other kind of medical specialty stood out as something you're interested in, or like you think is something you want to pursue? Because I know me personally, I got hooked on adding letters to my name. But I did that because I worked in a hospital where like I saw all kinds of stuff, and I like, it was like I was some kind of kid in a candy store. Like, I want that one, and I want that one. That one. So like, is there anything that you think an ED could form some pathway to another kind of career? Like, do they branch out? Because I started with general surgery. Well, actually, I started with cardiology, branched into general surgery, and then before you know it, I'm taking 15 pathways.
Well, with the ED, you pretty much get to touch every section of the CPT book.
yeah,
Because your coding services from every specialty, so you can pretty much go in any direction simply for that reason. And that's what I like about it, because you're not coding the same thing. I mean, you're going to be like, again, you're going to be coding from every section of the CPT book. You got Foley's, I mean, gastro replacements. I mean,
that's why I've always liked the ERs.
Yeah, you get to you touch everything.
All right. Yeah. So this is a gateway job.
Yeah.
It's a way for you to get a taste and feel for what you like. Is there anything any cases you don't like? Like, or anything like you avoid? For me, it's ortho.
You took it out of my mouth.
Ortho. Yeah, and cardiology for me.
I thought I wanted to pursue ortho, and then I'm like, no, I'll just stick with what comes through the ED.
Yeah.
All right. Well, we are again coming up in the hour. What time is it? It's 5 minutes. So let's leave it open for questions. So if people in the audience want to put a question on, I think I can get I can see questions asked through LinkedIn. So if you're on LinkedIn and you want to ask a question, I think YouTube might also allow questions. If you're tuning in on the YouTube link, put some questions in. We'll see if we can put a few answers out there. And if we don't have any within the next 35 seconds, we'll cut it short for the day.
And I just want to say too that HC Pro, they have it's probably outdated now, especially I know it's not updated with the new 2023 E&M guidelines, but they have an emergency department coding hand guide that, I mean, if you just want to get an idea of what ED coding is all about, and it's broken down in each section as far as the procedures that are performed in the ED, and it talks about critical care. I mean, that's a good book to purchase.
Okay.
That's cool. I didn't know that.
And you also mentioned there's an organization that you like with the
American College of Emergency Physicians.
Do they have a website or do they have any kind of publications that you recommend?
Yeah, they have a website. It's ACEP. And you can also search it by 2023 ACEP guidelines, and it'll be everything you need, all the facts and pearls.
That's ACEP?
Uh-huh.
Is that .org, .com?
I think it's .org.
.org. Okay, so if you're interested in learning EDs, you can look at ACEP, and hopefully they'll take you to something related to emergency physicians and not something related to like I don't know what else could be abbreviated ACEP. But I found out the hard way. One day I was looking up the AAPC. And I didn't know the web address, and I typed in aapc.org, and I was taken to the American Association of Pastoral Counselors. And I'm like, I don't think I'm in the wrong place. All right, so it is 3 minutes to the hour. We had no questions, which is odd, but I think everyone's head is spinning about what we talked about. But if you are interested in ED coding, and it's a fascinating field, it's a high-paced field, a lot of work and a lot of interesting things. Like I said, you run the gamut of all specialties, all organ systems, and you get to see quite a lot. Some is fun, some of it is not so fun. But if you are interested, I'd like to thank our panelists, Lakeisha Parrish and Kelly Hepner. They are good sources to go to on LinkedIn if you have questions or if you're interested. They can probably steer you in the right direction. Or if you have questions, you can ask any one of us. We're all on LinkedIn, and I will put up our information again. Kelly Hepner, if you want to, sorry, Lakeisha Parrish, first one. Spelling is Lakiesha, Parrish. She's on LinkedIn. Kelly Hepner is Kelly, spelled the long way, Kelleigh, Hepner. She's also on LinkedIn. That's how I found her. And if you have questions for me, my name is John Piskowski. I'm on LinkedIn. We do have a small growing website. You can point and laugh if you want because it's still under heavy construction. But I do answer a lot of the form submissions. I get an email when anybody fills out an information request on that website. But we are on LinkedIn, we are on YouTube, and eventually we will be on Instagram and Facebook once I figure out what those two services are. But again, I'd like to thank you all for joining us. It is 7:59. We'll be cutting short an hour. I want to thank my panelists, and join us next week, because in 4 days, we'll be discussing interventional radiology with two special, well-known coders. So if you can guess who they are, I will dance at your wedding. But it is a very good presentation on Monday the 8th in regards to interventional radiology, and followed by orthopedics. one of my favorite topics.
Oh.
Monday the 8th will be interventional, and on the 15th we're looking at orthopedics and orthopedic surgery. Again, thank you guys, and enjoy the rest of your evening. Good night.
Bye.
Bye.